Let's talk about a single number that can literally stand between a patient and a life-changing surgery. It's the body mass index, or BMI. It's used as a cutoff in operating rooms pretty much everywhere. But is that fair? And maybe more importantly, is it actually good medicine? Okay, let's get into it.
So, picture this. You've got a former athlete, right? Someone who has been active their entire life, but now their knee is so bad they can hardly walk. They're in constant pain. A knee replacement could completely give them their life back, but the surgeon says nope. Why? Because of a simple calculation using their weight and height, their BMI is just too high. And this isn't some made-up story. It's a real dilemma that plays out in clinics every single day.
And that really gets to the heart of what we're talking about today. Is it right for one single simple metric to be the ultimate gatekeeper for a procedure that could totally change someone's quality of life? We are going to unpack the evidence, the history, and the ethics behind this very, very common practice.
First off, let's just establish how widespread this really is. Because in many orthopedic departments, BMI isn't just a suggestion. It often acts like a hard and fast rule.
Yeah, this isn't just one doctor's personal opinion. We're talking about major institutions like the American Academy of Orthopaedic Surgeons. They point to a BMI of less than 40 as the accepted threshold for what they consider a safe elective surgery. Now, this guideline is definitely rooted in trying to keep patients safe, and it's based on data that says higher BMIs lead to higher risks. So, what exactly are those risks?
And look, to be fair, surgeons aren't just trying to be difficult here. There is a really compelling data-backed case for being cautious when you're operating on patients with a high BMI.
Now, check out this data from a huge meta-analysis by NHS Scotland. You can see how clearly the risk just climbs and climbs. Look at those numbers. For a patient with a BMI over 50, the risk of needing another surgery, a revision, for any reason is nearly 5 times higher. And the risk of that revision being needed because of a nasty infection, also almost 5 times higher. I mean, these are not small numbers we're talking about. And the risk isn't just in planned surgeries. This data from trauma surgery is even more stark. For patients with a high BMI, the odds of any complication are more than doubled. The odds of infection, they shoot up just as much. And, the most sobering part, the odds of mortality are a staggering 3.5 times higher. So, the takeaway here is that the concern from surgeons is very, very real. It is backed by a ton of data. But, what if the tool we're using to measure this risk is just fundamentally flawed?
And that question brings us to a major twist in this story, because to really understand the whole picture, we have to talk about where BMI even came from in the first place.
Get this. The body mass index wasn't even invented by a doctor. It was created way back in 1832 by a Belgian statistician who was just trying to describe the average man for population studies. He never, ever intended for it to be a measure of one person's health. Then, in 1972, a physiologist named Ansel Keys revived it, but even he admitted it was a crude tool, only accounting for about half the variation in body fat. And then, fast forward to just recently, 2023, and the American Medical Association itself put out a statement acknowledging BMI's serious limitations and advising doctors not to use it as the only factor in a diagnosis.
So here's the problem in a nutshell. BMI measures your weight and your height. That is it. It has no idea if that weight is muscle or fat. Think back to our university athlete. It can't tell you where on your body that fat is stored, which is actually a huge predictor of health risk. And, critically, it was developed using data from white European men, so it often misrepresents the health risks for people of different races, different sexes, and different ages.
Okay, so the measurement is flawed, but the risk data we saw, that still exists, right? Well, it gets even more complicated. Let's talk about this really strange phenomenon that has baffled researchers for years, the obesity paradox.
I know, it sounds completely impossible, right? For years, some major studies were suggesting that patients who were classified as obese sometimes had better outcomes, a lower risk of dying after surgery than so-called normal weight patients. This just flew in the face of all clinical experience and all the data we just looked at. How could a known risk factor suddenly look like it was protective?
Well, researchers found a crucial clue when they started splitting up the data. This protective effect, this paradox, it only showed up in studies that looked at planned elective surgeries, like a knee replacement. But when they looked at urgent surgeries, say for a hip fracture after a fall, the paradox just vanished.
And the answer turned out to be something called selection bias. The paradox wasn't real. It was basically a statistical illusion. See, for a planned surgery, doctors carefully screen their patients, and they only operate on the healthiest individuals with obesity.
But for an urgent surgery, they have to operate on pretty much everyone, no matter their overall health. So this pre-selection process created a mirage, making that elective surgery group look artificially safe.
So all of this brings us to the modern way of thinking. If these strict BMI cutoffs are based on a flawed metric and can actually deny care, what's the alternative? Well, the focus is shifting from a single number to a holistic, shared decision.
This one statistic just frames the ethical problem perfectly. Research has estimated that to prevent just one complication by enforcing a rigid BMI cutoff of 40, surgeons would have to deny surgery to 14 other patients who would have had a successful, complication-free outcome. That is a massive human cost for a tiny benefit.
So instead of a hard no, leading guidelines are now recommending a structured conversation using frameworks like this one, called BRAN. It's a simple but really powerful tool for making a decision together. What are the benefits of surgery? What are the risks for this specific person? What are the alternatives? And crucially, what happens if we do nothing? This whole approach moves the conversation away from a simple rule to a personalized risk-reward analysis.
And this is what that new approach actually looks like. You've got programs like the Get Ready program at Cleveland Clinic that bring in a whole team of specialists. They set personalized goals that go way beyond just a number on a scale, focusing on stuff like building muscle strength before surgery. They use modern tools, including the new anti-obesity medications, and they really embrace the idea that a personalized exercise plan is a form of medicine.
This quote from Dr. Seth Leopold, who's a huge voice in orthopedics, really sums it all up perfectly. The shift is away from these arbitrary, coercive rules and toward a real partnership. It's about having a fair, evidence-based conversation where the patient and their individual circumstances are truly respected.
So we'll leave you with this question. The whole story of the BMI cutoff really shows how a rule that seems scientific can be based on a flawed history and actually lead to unintended harm. It kind of makes you wonder what other hard rules in medicine might be long overdue for a much, much closer look.